Invite Dr. Sunil Thirkannad from Louisville, Kentucky. After all this, if the trapeziectomy works, if the tendon interposition works, if the suspension plasty works, and you have an option of tightrope, do we still have place for arthrodesis and arthroplasty?
Thank you, everybody. Thank you, Pankaj, for inviting me. The topic we need to address is if there is still a role for arthrodesis or an arthroplasty in CMC arthritis. I note that your theme is simplifying hand surgery, and I have taken that admonition very, very seriously. The first step is to understand the CMC joint. We all know that the CMC joint is a saddle joint, but in reality, it's actually a twisted saddle. So if you think of the CMC joint as a twisted saddle, I want you to imagine a road that looks like this. And that little car rolling over the road is your metacarpal. If you look at the way your hand moves, it's exactly like that. When you retropulse your thumb, it's all the way back and down, and as it starts abducting, it goes up, and as you bring it across your hand, it starts moving inwards. So, if you think of a car moving along in that direction or a metacarpal moving in that direction, what we know is that the center of rotation is slightly offset, and it corresponds roughly to the volar ulnar corner, which also means that if you don't want your car to fly off the road, you need something to hold it in place, and that controlling tether is your oblique ligament. So what happens in arthritis? Pretty simply, we now have a worn-out car that is being driven across a bumpy road. Your controlling tether starts becoming weak and lax, and as a result of which you start getting all sorts of deformities in your thumb. It starts subluxating outwards, and your first metacarpal starts adducting. You can no longer abduct your thumb, and hence you start developing compensatory hyperextension at the MCP joint. Well, so great, good. So what do we do about it? Well, we said arthritis is a worn-out car on a bumpy road. By that we mean the trapezium is the bumpy road, and the first metacarpal is the worn-out car. Is that entirely true? Well, it's not, because look here. What are we seeing? We have another joint below it, that's the STT joint. The trapezium moves on top of the scaphoid, which means the trapezium is not really like a fixed road. So what is the trapezium like? Your trapezium is like a trailer. So if you think about your whole CMC joint complex, what you have is a car riding on top of a trailer, which is in turn riding on top of a road. Very simple. So if things go bad, what do? If your car is broken down, you tow your car. And if your trailer is broken down, you somehow convert your car into a hovercraft so that it can float around. Very simple. What do we do by towing? The car is fixed on top of the trailer, and the trailer moves on the road below. CMC arthrodesis is like towing your car. It's fixed in one place and it moves at another place. What about hovering? Your car is floating on top of the road. That's exactly what you do in a CMC arthroplasty. Your metacarpal is floating on top of your scaphoid. If your metacarpal is floating, you want something that holds it up in place, and you need some kind of a strong tether that prevents collapse of your metacarpal. So to tow or to hover, that is the question. Which one do we use? Well, the trailer is designed to take a lot of load. So you can overload your trailer, but you cannot overload your hovercraft. The thing will collapse. So if you have a heavy demand hand, you're better off doing an arthrodesis. If you have a low demand hand, you're better off doing an arthroplasty. This is the data which I've collected over the last 10 years. I ran a rough guesstimate after this talk was given to me. I see about 2 new CMC arthritis patients every week. So that roughly translates to about 1,000 new CMC patients seen in the last 10 years. I initially start with the usual thing. I give steroid injections. I put them in a soft brace. If the patient does heavy manual work, I switch to a hard brace. And for whatever it is worth, I tell them to go and buy glucosamine and chondroitin sulfate and take it if they can afford it. And I tell them if you can't afford it, don't take it. We don't really know if it works. Which kind of patients are converted into surgery? Well, somebody who has persistent pain that is failing conservative treatment, or someone who has a hyperextension of the MCP joint, which is either very severe or where the MCP joint starts becoming unstable. So far, a total of 186 patients underwent surgery in my hands. Now remember, we have 10 surgeons in Louisville, so any data that I present here, you can multiply it by 10 times to get the total data from the Kleinert Institute. So we've probably done about 2,000 surgeries in the last 10 years on the CMC joint. If you look at the male to female ratio for surgeries, females outweigh male 4-to-1. 24 were arthrodesis, 162 were arthroplasties. The ratio is about 1:7. Now, when you look at the gender based on the kind of surgery done, in arthroplasties, females outweigh males 9:1, and when we did an arthrodesis, the ratio pretty much flipped to become about 11:1. Now, when I did my arthrodesis, I used no bone graft in about 13 of the 24, and in 11 of the 24, I used a primary bone graft because the trapezium looked pretty bad. So, I had 3 non-unions out of 24, which gives me an overall non-union rate of about 12.5. However, all the non-unions occurred in the group where a primary bone graft was not done. So that's about a 25% non-union rate. And all of them went on to unite after secondary bone. So when no bone graft was used, I had a 77% union rate. And when bone graft was used, I had a 100% union rate. So to conclude, how do we answer this question? Well, approximately 20% of the patients that I saw ended up requiring surgery, which means surgery, whether it is arthroplasty or arthrodesis, has an important but limited role. What kind of surgery? If it's younger, fuse. If they're male, you're more likely to fuse. And if it's a heavy manual worker, you're more likely to fuse it. Should we do primary bone graft? Definitely, if the trapezium looks unhealthy. I'm not sure, probably. Maybe there's a role because you can improve your union rate from 77% to about 100%. And finally, I'd like to conclude with this personal thought, which I think almost anybody in this room will agree with me, that your CMC arthroplasty patient is probably one of the most satisfied patients you will ever see in your practice, no matter what method you use to do the CMC arthroplasty. Thank you very much.
Thank you, Sunil.